Welcome to the Beverly Hills Plastic Surgery Podcast. I'm Dr. Jay Calvert today here with Dr. Millicent Rovelo, and we are both wondering, does this hat make my nose look flat?
I was going to say something, but I wasn't sure.
We are talking about how to fix my flat nose.
It's a problem.
It's a problem for many reasons, and we're going to go through why you would have a flat nose and what to do about it, because it's a huge complaint that brings people in for rhinoplasty.
Correct. And so, to be clear, we're not talking about like flat noses, like the nose is not gone. But these are just people that, for whatever reason, they have noses that don't project up or very high off their face. And for plenty of people, that's okay, and they're totally fine with that. But some people would just like to have a little more projection and a little more height on their nose.
Right, and this is common in several instances. First of all, the one that leaps to mind is Asian rhinoplasty. People come in, they want a bridge. You know, my bridge isn't high enough, or I barely have a bridge. Which
the bridge is the top part of the nose.
Yeah, this part right here. This part that goes from the forehead down to the tip of the nose. Yeah. That is the bridge, also called the dorsum, the dorsum of the nose. They say, I have no dorsum, and they'll come in with a type.
Do they say that?
Well, because they come in after they've, internet and Dr. Googled themselves. They'll come in and say, like, I need you to fix my dorsum. And I'll be like, oh, really? What else, fancy britches? Say something else.
All right, so they know what they
know what it is. Yeah. And so they want a bridge. And then the other people that need bridges are people that are born with congenital issues, that some cleft syndromes that go through the nose that cause them to not have a bridge of the nose. Trauma also can eliminate surfboardectomy of your bridge of your nose. They crunches it, telescopes it into your face.
Yep.
That happens.
Cheerleading accidents.
Cheerleading is it's rough. It is rough on noses, and
yes,
it is a cause for many a rhinoplasty in my practice.
Oh yeah, big time. And then you can't forget about the self-induced, drug-induced.
Oh yes.
Collapsed noses.
The vasoconstrictive agents, such as too much Afrin. That's what it is. I sprayed too much Afrin in my nose. Oh, and cocaine. Yeah.
And
so those things can all cause the bridge to collapse.
Yeah.
There's also people that don't have a bridge from autoimmune disease, which I work on many of these people that it is like, these are disaster cases of my nose is too flat. And this is where, I have a patient and it's unbelievable. They wake up one day and they see their nose changing. And this one patient, over a 2-week period, lost her nose.
It is bizarre. It is crazy, and it's so rare. So people don't go out there and start measuring your nose height every morning. It is not common. It's very,
but for those
very
it happens
rare.
to, it is devastating because it's also a part of a disease process that is very rough on the rest of your body as well. Right. And these autoimmune diseases are really tragic. But what we want to talk about today is that, so if you have a flat nose, for any of these reasons, what are the strategies to build it back up? And I will just tell you that in my experience, you have to use some kind of combination of cartilage grafts to push the nose off the face, and then you might use something like a diced cartilage and fascia graft to build up the bridge. And what that is, diced cartilage is cartilage literally cut up like minced garlic. I always look for the nurse who likes to cook to do the dicing, or the fellow that loves cooking and can mince garlic, right? And then you mince it up. We use, some really straight blades basically to do that.
And this is cartilage from what
wherever.
source?
It could be anywhere. It could be septal cartilage, ear cartilage, rib cartilage. It could be allograft rib cartilage, which means cadaver. Yeah, like we bought somebody gave it the office and we're using their rib. But dicing it up and wrapping it into either deep temporalis fascia, which is fascia is the lining of a muscle. It's the thick kind of coating, akin to like grizzle on a steak. And that fascia is used as a wrap to control the diced cartilage. And, with a combination of even some solid grafts underneath to push it off of your face, rebuilding the septum, all those strategies come into play. And it really depends on kind of what you need.
Yeah, I mean, for most people, what they need is height, but they also really need support. So it's not enough to just stick you could just stick an implant on, right? So that's an option.
I Wasn't going to mention dorsal implants because I try never to use them, but you could definitely use like a silicone or PTFE, or an ePTFE dorsal implant.
And why don't you like to use those?
Because they get infected, and I don't think they look very great, and they're just not my faves. I really like to use your own tissue.
Yeah, and for the most part, a lot of times
you can do it.
You can do it.
I hear Gary Tierston right now, like in my ear, going, "Yeah, but they work."
They work for that one problem, giving your nose a little bit of height. And hopefully you don't have any complications related to infection or extrusion. I don't know how many patients I've seen in your office with like the implants literally like coming out of their forehead.
It comes out either out of the tip of their nose or out of the forehead, one or the other.
Yeah, it pushes its way through the skin. But like you're also...
I published a paper on that problem because I
published the paper.
Oh, you did that?
Right, it was you and I together. Yeah. I was like, I know.
I just work here.
But also, like, I mean, you can use the implant, but you're also going to usually need to do some other kind of robust structural support to the nose as well, because just putting a little dinky implant on top is not going to fix the rest of the issues that the nose probably has in addition to being low in height.
Especially with these, complex reasons for flattening of the nose. So one of the most common operations around the world for Asian rhinoplasty is making a small incision inside the nose and putting in a silicone implant. Yeah. Takes like 15 minutes. It's done under local anesthesia, and it solves the problem. And it is a good operation. So I don't want to disparage Gary Tierston because he's one of my favorite people and a great guy. And he's just like, they work, Jay. Like, you need to talk about it. I'm like, so I'm talking about it. Here it is. I got you.
Yeah.
But I prefer to use for those cases like a diced cartilage and fascia graft, like I did today. Diced cartilage fascia, septal extension graft, lateral curl strut grafts, alar base excisions, Asian rhinoplasty, beautiful. Looks amazing. And it's their own tissue. And it's not going to go anywhere. And it's not going to become a problem down.
It doesn't get infected.
No,
Does
and
it absorb? Does this diced cartilage fascia... So DCF is the fancy term for it. This diced cartilage fascia graft that you've made, this little Tootsie Roll.
I prefer to think of it as a burrito. California roll, something.
Okay, yeah.
Whatever you want to call it.
Something wrapped and filled with like juicy goodness.
Yes.
Does it stay the same size or does it absorb?
What you see is what you get on the table. That's what you're going to have, and it doesn't absorb unless it gets infected.
Right.
Now, infections are rare. I have seen 2 infections of a DCF graft. One was in a 17-year-old kid who went out and got into fights after, and he ripped his diced cartilage, his fascia graft harvest site open. All the staples were out, and then it got knocked over to the side, and then it became infected. So that was one.
So don't do that. Don't do that.
And the other one was when I used, and this is like the rhinoplasty surgeons listening are going to go, huh, I used banked rib cartilage that was put into the scalp of somebody who'd had a rib graft, and I took it out. I said, oh, great, I'll dice this up, wrap it in fascia. Well, I did, and I put it in the nose, and lo and behold, the whole graft absorbed. And I was really upset because A, I didn't expect that, and B, I had to redo it.
Yeah.
So I don't know if it was from a low-grade infection, but those are the 2 times I've seen it absorb.
Yeah, those are pretty specific instances.
They are, and when I've done them the other way, it's what you see is what you get. I mean, I always think about my nurse that I did, Orla, my PA, and I had just gotten back from doing a overseas, operation for somebody who came back to doing 8 rib grafts in one day or something crazy like that. And we did a DCF graft on one of our nurses, and that was in 2011, I think. And to this day, her graft is perfect.
Yeah.
Without, and I see her all the time. So that's been 14 years, and it really hasn't changed at all. And her nose looks great. And so, I think the diced cartilage and fascia. Now you go to some meetings, and there's always, one joker who stands up in the middle of the meeting and says, yeah, nobody does diced cartilage and fascia anymore. That's something for the past. And then 40 of us go, I still do it. Well, I still do it. And Sam Most from Stanford just posted a huge thing about doing diced cartilage and fascia for complex secondary rhin. I mean, we all still do it.
Right.
Except for one person.
Yeah. And what would be the option, the alternative to not doing a diced cartilage fascia graft?
Well, you could do a solid graft.
So just a solid piece of cartilage.
Yep.
Just
carve it up. Yeah.
Like an implant, and just slide it in there.
Whittle it and put it in there. Yeah. The downside to that is it can go one way or the other. It can twist. They do warp. I remember having a plastic surgeon in my office saying to me, the reason I love doing solid rib grafts is they never warp the way I carve them. And then I pulled up one of his patients that I had redone, and I said, like this? He goes, Oh, that's where he went. He was like, that's pretty warped. I was like, they do warp, and they do.
Curve.
And I had them from top line surgeons where they warp, and they warp in my hands too. Because I still will use solid grafts in some instances. So like, I'm sitting here saying like, I never have complications. I have complications like anybody else. But DCF minimizes the complications in terms of bridge height elevation. It really works in my hands. Those of you it doesn't, great, do something else. But it's powerful, it looks nice, and it works, and it has minimized the complications in my hands of these reconstructive cases and these primary cases where I'm doing these Asian rhinoplasties. And I think Ed Kwan, who is one of our fellows in like about 10 years ago, he's like a master of this. He's really good at it. And he always talks about dice cartilage and fascia because he does so many and he gets such great results with it that it is hard to ignore it and say like nobody does that anymore. So
I think one of the coolest things I've seen you do with dice cartilage fascia grafts was in the postoperative period where it just wasn't quite in the right position, and you can literally like mold it on the patient in real time. You can inject a little bit of
Hyalin X in there,
and soften it up, and then be like, I really don't like where that's sitting. I'm just gonna like move it over to this part of the nose.
You 100% can do that.
You just molded that patient's nose on the table.
Yeah, and you can wait like what they do is they come in, they're like, oh, this is a little high here or something. And this is even like 12 years after I've done them. And, and I think it was Roland Daniel that called me one time. He's like, well, do you think I could do it on like a 6 years out graft? I was like, yeah, why not? And, you put in the Hyalin X because what it does is it dissolves the scar tissue that's between the little dice pieces. When you look at the histology, the microscopic view of what the dice cartilage fascia grafts look like, the little pieces of dice cartilage are like little cartilage grafts because you've cut them.
Right.
People say, what if you crush the cartilage? That's different. It disrupts it. With the dice cartilage, you're making teeny tiny little cube cartilage grafts that just sit there. And the tissue in between them is just scar tissue. It's collagen and elastin. And so when you put Hyalin X in, it breaks up that matrix, and you can mold the graft. And it's good for 12 years after that was my latest one. But it's pretty rare that I even need to do that. But it does work.
But it is cool. It is, and it's nice to have that option if you need it.
Great way to build up a bridge. Solid grafts work. I tend to do a combination of doing a L-strut, septal elevation first, made out of rib cartilage, and then putting a dice cartilage fascia graft over top of it. That's really kind of the way that it works the best. In my hands, I always say that because it's like, other people are like, well, you said it works the best, and I did it, and it didn't work. And it's like, rhinoplasty is one of those things, like, you have to go with what works for you. It is so user-dependent, technique-specific. We kind of, talk about things like everyone should do it the way that we do it, which I don't.
No.
I never think you should do it the way that I do it. I think you should do it the way that it works best for you. If what I do works for you, great, do it. But rhinoplasty is so specific to the surgeon and to what the patient needs. Yeah, I think that's pretty much it. Anything else you want to say about the DCF grafts? Well, DCF, I think... I think the one thing that is the downside of the DCF graft is you're making an incision, usually for the deep temporalis fascia, or, if you're taking a rib, then you're taking some fascia graft off the rectus abdominis muscle. So it is another donor site. So that, it's a little bit of a drawback. I mean, people are okay with it because this heals well up on your head, but it's something you have to consider. It's a little more complex, But the results are great. I got, some 6,000 rhinoplasties under my belt that say it works. So, I think it's a good way to go. In your hands. In my hands. Right. Not in, I don't know anybody else that did those 6,000 rhinoplasties. I think, and I think the people that use it they're pretty into it. And the people that don't, obviously, they don't need it. And that's always the other thing too, because people will come in and be like, oh, are you going to do, this technique, or are you going to try this preservation technique? I was like, I'm going to do the technique that's going to get you the best results in my hands. So telling me to do your operation with some technique doesn't make sense. It's not how surgery works. Yeah. What you do is you look at the before and afters that the surgeon has on their Instagram, their website, and their TikTok and all that, and you go, I really like those. And that's where you go. Yeah. You say, this guy's got his head screwed on straight. He does some really nice work. I want that.
Yeah. I could not agree more.
Well, in that case, this is the Beverly Hills Plastic Surgery Podcast, coming to you from the 90210.